Hello, my name's Dr. Joan Ostaszkiewicz. I'm a registered nurse, a continence nurse advisor and a researcher. My interest is in supporting formal and informal carers to provide optimal care to frail older adults with incontinence, including frail older adults with dementia, and to ensure that they have access to diagnosis and treatment. Many frail older people have potentially treatable causes of incontinence. In fact, there's a study from the States that shows that 82% of frail older adults living in residential aged care facilities have potentially treatable causes of incontinence. So whilst we know that incontinence can be caused by physiological factors, this is not always the case. There are multiple factors external to the bladder and bowel that can cause or contribute to incontinence in frail older adults. For example, the single greatest risk factor for fecal incontinence in residential aged care facilities is the inappropriate use of laxatives, and this is something we can and we should do something about. The single most predictive factor for urinary incontinence among frail older adults is impaired mobility. Obviously, when we become mobility impaired, it means that we become dependent on another person for assistance to go to the toilet. But such assistance is not always available. In my PhD study, where I interviewed staff working in residential aged care facilities, staff indicated that they struggled to provide this form of assistance on a regular basis. The second greatest risk factor for incontinence in frail older adults is impaired cognition. Currently, 52% of people living in an Australian residential aged care facility have the diagnosis of dementia. They are also very elderly, frail, and they have a shortened life expectancy. Having dementia complicates the management of incontinence because people in the latter stages of this disease have little insight into their own care needs. As their dementia progresses, the individual's care needs increase, including their need for assistance with bladder and bowel elimination. Providing continence care necessarily involves doing very personal care, and people who are cognitively impaired don't always understand or appreciate the nature of this care. It takes skilled communication to be a carer. So what we should be doing is teaching both formal and informal carers how to deliver continence care in a way that ensures the person with dementia feels respected and safe. The third major factor that contributes to incontinence, particularly in institutional care settings, is the physical environment that can make it difficult for the person to remain or to regain continence. Here I'm talking about toilets that might be difficult to access, a lack of privacy, limited toilet rails, and things that most of us take for granted, such as clean toilets, the availability of soap and water, etc. The systematic implementation of a toileting assistance program, combined with the low-intensity endurance and strength training exercise program, is the most effective way to prevent incontinence in residential aged care facilities. This type of program also has the benefit of improving residents' physical function. Of course, not every frail older person will respond to or benefit from this type of program. However, research tells us that when residents are offered toileting assistance on a consistent basis, facility rates of incontinence fall dramatically. The challenge, however, for staff is to identify residents who are most likely to respond to this type of program and to maintain the program over time. It should be said that providing residents with toileting assistance does involve more time than the time involved in checking and changing a resident's pad. And it requires a staffing level that is higher than the usual staffing levels in most facilities. Another factor I want to pick up on is the effect of tacit beliefs about age and incontinence that can inadvertently socialise frail older adults into becoming chronically incontinent. At a rational level, we know that all older people are not the same, and we also know that not all people with dementia are the same. They are not all incontinent, and they have not all lost all decision-making capacity. Indeed, our social values about continence are so strong that the loss of bladder or bowel control is one of the last skills people with dementia lose. In my practice, I've found it's not uncommon to find people go to extraordinary efforts to avoid being incontinent, even when they have early to mid-stage dementia. At the same time, most of us have deep-seated beliefs that old age, incontinence, disability, dementia, dependence are necessarily linked, and that incontinence is an inevitable and irreversible symptom of old age, disability, or dementia. The problem with these beliefs is that they can inadvertently socialise people into accepting their incontinence as normal and to avoid seeking help. They can also cause us as carers to accept and normalise incontinence when what we should be doing is conducting a comprehensive evidence-based assessment to identify and actively treat and manage incontinence. What I think we need is a public health campaign that acknowledges the rights of all older people, regardless of where they live, their rights to assessment, treatment, behavioural interventions, and more importantly for frail older people, to toileting assistance programs. According to research findings from the US, current staffing levels in most residential aged care facilities are insufficient to provide residents with toileting assistance at rates that reduce their incontinence. Therefore, it's not fair to blame carers or frontline staff for the high rates of incontinence or for their focus on padding incontinence. Based on my PhD findings, staff are doing the best they can under the circumstances, and I found that many residents and family members were aware of this fact. Incontinence in frail older adults is a multifaceted problem that warrants an equally multifaceted strategy. This strategy should tackle ageism and its damaging effects. We also need to be clearer about the links between staffing levels and the quality of residents' care, including the quality of their continence care. We need to ensure that residents receive a comprehensive evidence-based continence assessment to identify and inform their continence care plan. And we should be involving all key stakeholders, residents, their families, staff and service providers in decisions about day-to-day care. We need to know what their preferences for care are, and these preferences should underpin the delivery of care. I would like to think that quality continence care for frail older people is care that is delivered in a manner that doesn't humiliate them or shame them for episodes of incontinence. It's not rushed, it's consistent, i.e. it's provided regularly. It respects their privacy and their dignity. It makes them feel safe. It protects their skin, optimises their remaining abilities, is individualised, respects their autonomy and their right to take risks, including their right to go to the toilet on their own. And again, it's based on an evidence-based, comprehensive assessment that is undertaken by a multidisciplinary team who are able to identify and treat reversible causes, including both physiological, socio-cultural and physical causes. Thanks for taking the time to watch this video.